Thanks, Dr. Eunice Minford, for talking to the Op Report today. You are a surgeon trained mostly in the UK, but you also had some experience in the United States, and I think your perspective is interesting. So the first trial, the flexibility and duty hours restrictions for surgical trainees, set out to prove that restricting training hours wouldn't improve patient care. And I think the hope was to show the governing authorities that tinkering with our training system shouldn't be taken lightly, that tinkering has unintended consequences, and that changes to our system should be evidence-based. And there was a lot of activity around that trial. A lot of surgeons very happy that this sort of demonstrated the case that these changes hadn't improved our system. On your blog, The Soulful Doctor, you made some observations I thought that were interesting, and that your perspective was an interesting one, mostly about how the first trial was conducted. So tell us the concerns you had about the human subjects research and the consent for doing this study.
Yeah, well, the first thing that struck me when I read the paper was that it was classified as non-human subjects research. And I thought, how can that be when clearly human subjects have been subjected to an intervention that potentially affects their quality of life? And so I looked up the supplementary information that was supplied with the paper. And when I read that, it seemed to me that the trial had been, if you like, miscategorized, or there had been a sort of fudging of information in terms of how it was classified on the IRB form, because it said that in order to be non-human subject research, that it had to be limited to data that was already being collected. And whilst the surveys that were used in the first trial were already being collected, the trial wasn't limited to that. There was an intervention that was applied, albeit as they described it, to the different programs. But that intervention was ultimately going to affect human subjects. And to me, it seemed, on looking at that form and the IRB form, that it really should have been classified as human subjects research. And that would no doubt have led to a more in-depth review and ethical review of the trial.
Sure. And you also made a point about whether or not the doctors were working 80 hours in the two groups. And that, can you speak to that?
Yeah, well, obviously they outlined in the paper that one of the criteria was that in each group the doctors should not exceed 80 hours per week or of work over a 4-week period. And it seemed to me that they hadn't actually taken any steps to assure whether those in the flexible group were adhering to those hours. In fact, they actually stated in the information that adherence to the study protocol in that regard was not undertaken. So they didn't record any duty hours or sleep obtained by residents. And it also, because some of the results of the trial showed that the residents felt that they were missing out on time with family and time at work for rest and health and extracurricular activities, that it seemed that they must have been working more than 80 hours in order to have that compromised. Because if both groups were working up to 80 hours, surely they would have the same amount of free time in order to recuperate and have time with family and friends and all the other activities that they were doing. So again, it seemed like, although they stated that that both groups adhered to that, there wasn't the evidence to support that in terms of actually showing that the 80 hours was adhered to in the flexible group. And I think if you have that as the standard group, and then you waive all the restrictions on the hours of work for residents, then it seems logical that they're going to end up doing more than 80 hours.
Right.
And there was no mention of, for me, even the word flexible was a bit of a misnomer, because it wasn't really flexible. It was just waiving all the restrictions and prolongation of hours. There was no mention of people coming in late to work or finishing early, or in terms of what I would consider more a flexible program.
Yeah, it was flexible relative to the imposed guidelines, not flexible for the study participants.
Yeah.
And you did part of your training in an American hospital.
Yeah.
Tell us about your experience in terms of how your work hours were when you were working in the United States compared to in the United Kingdom.
Yeah, they were vastly different. I worked as a transplant fellow in one of the major American centres, and it was back in 2002, 2003. So I think they had just brought in some restrictions on the duty hours for residents in general surgery, but this didn't apply to the transplant unit. So there was 5 fellows, and we were basically working 24/7, and would have got 48 hours off once every few weeks. So from a Friday night to Sunday night. I think the shortest time was 2 weeks between a break, and the longest time I did was 6 weeks. And the rest of that time you were basically at work, and you got maybe 1, 2, 3 hours sleep a night. And that's not an exaggeration. That was actually what happened. And the fellows were, we were all often exhausted. I know one of my colleagues reported falling asleep standing up assisting in theatre. When I was going off for my 48 hours off, often the other person on the other end of the line would fall asleep, and they were the ones staying behind, to carry on working the weekend. So the levels of tiredness and exhaustion were quite extreme, really. And I, cannot see how that can be safe for patient care, even though there is the continuity of care. That level of sleep deprivation and exhaustion definitely takes a toll.
Right.
Not just on the quality of patient care, but on our own health and well-being, of course.
Sure. And what in your blog, you made a reference to bias or an agenda of those conducting the study. Can you tell us about that?
Yeah, well, I understand the surgical mindset, the surgical culture, which has that kind of macho attitude, and sort of that the view that the longer hours we work, the better we are as a doctor. And I used to have that myself. I used to be fully signed up to that way of thinking. But I've come to realize that it's simply not true. And for me, it seemed that there was an agenda, if you like, by the old school of surgery to try and justify these long hours of work again, which are, that degree of long hours of work I find is abusive. I feel it is abusive. And it's detrimental to the residents' health and well-being. And of course, when we are trainees, we're very keen to learn, and we're very keen to spend time in theatre and put in all the hours. And I understand that. But it does take its toll over time. I think, my younger self would be surprised at my older self saying what I'm saying, because, I had the attitude that many of the residents have expressed with regards to training and long hours of work and that kind of thing. And I would have been an advocate of that. But life has taught me differently. And, I've come to understand that if we really want to improve patient quality of care, we actually need to improve our own quality of care for ourselves, that the staff need to be looked after and cared for. And then they will be more able to truly care for the patients as well. So I've changed in myself and my understandings in terms of seeing that to deliver a true quality of care to patients, we have to be living that for ourselves in order to have a lived quality of care to give to our patients. In that sense, we can't give what we don't have. Sure. So if we're not looking after ourselves on those basic needs of, rest and sleep and food and exercise and and obviously much more than all of that. But then we're not caring for ourselves. And what then is really the quality of care that we're giving to our patients?
Okay, all right. Last words on the first trial.
Yeah, I find that there's a number of issues with that trial. And one of the other issues, which I didn't blog about, was whether there was actually a full ethical review of it. And, it seems to me unethical in that sense, in terms of how it has actually been conducted. And the thing is that I'm not advocating one arm or the other arm, because I think neither of them are actually about looking after and caring for the surgeons and the trainees in the first place. And I think if we're actually to change the culture of medicine and surgery in a beneficial way, we have to actually begin to make a priority to care for the trainees. And all too often, that's not happening, and it hasn't been happening in the culture of medicine, and hence why we have high rates of burnout, addiction, suicide, all the different things that are happening in the medical profession, both in America and in the UK. So, I understand where they're coming from with it. I understand why what the impetus is behind it, but I don't agree with it in terms of I think there was another editorial about it which also highlighted that, it's not about going back to those days of abusively long hours of work. It's about finding systems and processes and ways that we can work hard, but in a way that's healthy and not detrimental to our health and well-being. And I think it's not about, I understand the need for continuity of care and having as good as possible handovers and exchanges and things like that. But it's definitely not about going back to those abusively long hours of work. And it needs to, I think the emphasis needs to change in that sense, in terms of bringing more care in to look after the trainees and the surgeons, and in that way to get more out of them. And I think there are ways, and we're not taught this in medical school, in terms of how to live in a way that is truly healthy, so that we can work hard and also, still be able to have a good family time and not come home exhausted, depleted, and then the family gets what the remains of what's left after your hard day at work.
Right.
But how to stay healthy throughout both work and home time. And there are ways that we can do that, but it's not in mainstream teaching as yet.
Right. Well, thanks again for your perspective on this, Dr. Eunice Minford.
Thank you.
Bye-bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.